Hi, greetings from Melbourne, Australia. My name is Eric Levi. I'm an ear, nose, and throat surgeon. I'd like to talk to you very briefly about modifications in sinus and nasal surgery in this era of coronavirus. What's happening here today? We are um, on the 22nd of March 2020. I'm recording this almost certainly with a rapidly evolving pandemic. Um, I'm almost certain that in the next couple of weeks, some of the things that I'm saying might actually be obsolete. But these are the challenges that we face on the 22nd of March 2020 around the world. We know that ENT surgeons are at higher risk and we have higher rates of contracting the virus pandemic at the moment with COVID 19. Data from China and Italy and many other places have shown that ENT surgeons are falling ill, catching the virus. And we even know of some death and mortality of ENT surgeons who have probably been exposed to the virus unknowingly. It is thought to be due to the fact that there is high virus load in the nose, nasopharynx, and oropharynx, even in the asymptomatic carriers, and therefore we might actually be examining and operating on asymptomatic patients with high viral load in the nose, nasal cavity, oropharynx, and sinuses. And therefore, this may explain the reason for the concern about morbidity and mortality of airway surgery. Any airway procedures that are aerosol producing are therefore high risk and places the staff at risk. These procedures on the ward, including nasal endoscopies, cautery, even a standard nasal or oral examination, may actually be exposing frontline staff, including anesthesiologists, ENT surgeons, emergency physicians, and general practitioners to high viral load. Therefore, we need to be thinking of if these interventions or procedures are necessary in the first place. We do need N95 mask, gowns, gloves, visors, and eye covers for our routine examination. However, what about patients who do need airway intervention? Anything that potentially produces aerosol and that contains virus includes sinonasal surgery, adenotonsillectomy, laryngobronchoscopies, and other things may have to be delayed. However, there will be some severe patients, urgent patients, cancer patients, or even critical airway cases that need to go ahead on a case to case basis. And therefore, in this day and age of COVID 19, we need to be thinking hard about the intraoperative risk reduction strategies. I'll go through some of these. Um, COVID testing is still very limited in Australia, and you need to meet stringent criteria prior to getting testing. And therefore, at this stage, we cannot screen everyone for COVID 19. In the future, however, we should be thinking about pre-clinic or pre-operative COVID status assessment. However, that's probably after the wave has passed, and it is not possible at this time. So, what happens if you have a patient who requires an emergency or urgent or malignant sinus or nasal operation that cannot wait? And these are the things that we need to be thinking about. Could we check their COVID status preoperatively? Some places you can do that, in some others you might not be able to do, and therefore you need to assess the patient on the basis of its low or high risk of being a COVID positive patient. At the end of the day, even if the patient is at low risk, they are potentially have to be considered as an asymptomatic carrier. The goals of any operation is to perform a safe operation. However, in this day and age, we need to reduce the risk to the surgeon and healthcare staff due to the high risk of aerosolization of virus particles in an airway operation. Therefore, we need to think hard about modifying our technique or improvising our technique to mitigate these risks. Um, what we do or how we improvise today may be the new normal for the way we do these things in the next 3 to 6 months. So it's worth thinking hard right now about what to do in a context of an emergency sinus or nasal operation in a COVID patient. Our mitigation strategies that we've thought about in the operating theater, we need to be thinking hard about who needs to be in the operating theater itself. Reducing the number of staff members involved in the case and reducing movements in the operating theater would reduce the number of people that could potentially be exposed. Personal protective equipment is obviously necessary for every team member involved in this case. In the anesthesia intubation period, of course, they do need to think about PPE. However, also in addition, we need to think about endotracheal tube to seal the airway. Previously, I have operated on sinuses with laryngeal mask, an LMA, in situ, but an LMA may well create a lot of leak and therefore create potentially aerosolization of oropharyngeal debris or particles. So it's worth thinking about using an endotracheal tube. Throat pack may help. Two lines of thought here. Something that throat pack will pack the oropharyngeal mucosa and keep everything at bay, reducing the amount of aerosolization. But another line of thought would be that as the throat pack is removed, the throat pack might actually contain a high viral load. So being careful with the removal of throat pack is critical. There is no evidence either way, and therefore this has to go back to either common sense or your own personal choice about the matter. Preparation of the nose. Typically I would use topical sprays or neuropathies. Again, there is a concern about aerosolizing nasal particles with a topical spray. The challenge with applying neuropathies or patties or pledgets in the nose is that you will be bringing yourself close to your nose, close to the patient's nose, and therefore risking exposure. Our goal is to try and distance or create a space between the operator and also the patient. Injection usually typically is done with headlight. Again, in this day and age, I've decided to leave the injection intraoperatively rather than preoperatively prior to scrubbing. And again, this is to reduce the amount of exposure to particles being proximal to the patient when prepping for the nose. And a few other things to think about during the setup, routine prep and drip. Normally, I would leave the upper lip and mouth open, but I have decided to consider closing the mouth and also closing the eyes with Tegaderm if you were one who leave the eye open. Again, there are some reports of ophthalmologists catching the virus through exposure and proximal exposure to virus load in the eyes. So therefore, I've decided that reducing exposure of the cornea that may contain some viruses might actually help. So therefore, Tegaderm. The additional thing that I do is placing a bar over the upper chest with a sterile ultrasound cover. I will show some pictures to overlay a plastic sheet to trap any aerosolization. Once the instrument is set up as per normal, I then apply a sterile plastic drape to cover the whole head with the hope of potentially trapping aerosolized particles. Again, the goal here is to reduce any aerosolized particles that might be spread within the operating theater itself. I'm trying to reduce any exposure of these particles to our staff members. I've also added a third suction to be placed near the nostril for again additional suction. The first suction is the instrumental suction, the second one is attached to the microdebrider, and the third one is placed near the nose for additional suction. The instrument nurse, who is obviously gowned up with their PPE, stands at the head of the table. Usually they would stand opposite or contralateral to the table. However, with the plastic drape over the whole patient, it is easier to transfer instruments to the head of the table. And these are the pictures. So patient is prepped and draped in the usual fashion. A bar that is laid over the patient with a plastic sterile cover. I use an ultrasound sterile cover just to cover that bar. And then the plastic drape that goes over the patient. This is how it appears from the head of the table. The surgeon's instrumentation hands or working hands are both within the plastic drape. This is a picture from the foot of the table. It is surprising that you could actually do have some movement here. Remember that the bar has to sit high enough to allow free movement of the instruments going in and out of the nose. Again, all of these things are done to trap any aerosolized particles within or under that plastic drape. The drape is clipped on one side. The instrument nurse stands to my left or on the head of the table, towards the head of the table, so that they could pass any materials or instruments under the drape. what if we post-operatively as well? There's some minor changes. We wake the patient in theater, not in recovery. In the past, with the LMA, sometimes we wake the patients in recovery. However, we have decided that waking up the patient in theater to reduce coughing, spluttering during emergence will be important. We have decided as well again to reduce the number of staff members during this emergence and extubation. We place nasal bolster and mask on the patient, again to reduce any potential aerosolization. We then place the patient in a suitable recovery area that is sealed off from the rest of the recovery room, and placing the patient in a single room on the ward would help as well. So what have we learned through modifying or improvising this technique? It is reasonably easy to set up an additional plastic sheet and a bar. Is not costly, easy to modify, and it's reasonably practical. There is initially a bit of ergonomic challenge with obviously operating under a plastic drape. However, we are quite surprised at how easy we pick up and how easily maneuverable the instruments are. There's a little bit of a slow instrument passes initially, but we gotten used to it. And again, just like any learning any new technique, the nursing staff and the surgeon do pick up this modification quite easily. The challenge also is the instrument nurse still handles contaminated tissue. If the nasal mucosa contains a lot of virus, then handling these tissues that is removed from the nose is quite critical. So every tissue that we pull out need to go into a sealed jar, preferably under the drape as well, to try and limit the amount of debris or tissue that is outside the sterile drape. Again, we admit that this is not 100% foolproof, but it seems to work, and we do think that it would reduce aerosolization of particles. Be very careful when removing the drapes at the end. The last thing you want is to flick the plastic drape or actually dispose them improperly, and therefore being careful is quite critical. Important to note, during emergence and recovery, patients would cough and splutter, so being careful with waking up in theater and also watching for coughing and gentle waking up will be critical in that situation. Again, this is a rapidly evolving pandemic. We are learning to modify our techniques and our approaches in this COVID-19 era. What we're learning today is not perfect. Hopefully, there'll be some improvements and improvisations over the next few weeks. And what we learned today is pretty critical as well, because what we are modifying may well be our new norm in the next 3 to 6 months. Thank you kindly.